Sure.
Hi, good afternoon, everyone. Welcome to THETA Rounds. Today we have a special guest who came from the University of VC. It's Mohsen Sadatsafavi.
Yeah,
Good?
perfect.
Good. So Mohsen is very well trained in different disciplines. First with a foreign trained MD from Iran, right?
Yes.
Then master degree in epidemiology, and then PhD in health economics and outcomes research. So it's a great pleasure to have you at THETA. He will be speaking today about developing a reference model, a reference policy model for precision medicine technologies, and some of the challenges and lessons learned during the process. Also, before Mohsen starts, we will introduce ourselves. So the speaker has an idea who is in the audience, so I will start. So I'm Val Rek. I'm Associate Director of THETA. I'm scientist with Ted Rogers and faculty at IHPME.
Hi, I'm Wilson Ryan, IT architect.
I'm Lina Reyes, I'm the admin coordinator at THETA.
I'm Shane Lilly, I'm a PhD student there here.
I'm Aisha, I'm also a PhD student.
Austin, I'm a PhD student there.
Then I'm not a PhD.
Good for you.
Hi, I'm Alexandra. I'm Dr. Postdoc.
I'm Rafael. I'm a postdoc here. Troy Francis, research associate at THETA.
Yeah.
I'm Natasha Gray. I'm a research coordinator at THETA, working with Teresa Tso on her team.
I'm Rachel. I'm also a research coordinator working with Dr. Teresa Tso at THETA.
Teaching to advise this teaching and also with postdoc.
Okay, so now.
I am Teresa. I brought my whole group here.
That's good, that's good. We like that.
I'm researcher at THETA, and also professor at
Andrea Gershon, nephrologist in science.
I'm Laura Feldman. I'm a research analyst working with Dr. Tso at THETA.
Matthew Stanbrook, respirologist here at UHN and scientist at ISIS.
Perfect, fantastic. Okay, so
Thank you. Can I have the portable mic?
Yeah,
I kind of tend to walk.
sure. And we have some people online. Sorry, before you start, right?
Yes, that's right. Yeah, we have 3 people online,
Okay.
and actually, Petros as well.
Oh, say hi to Petros, of course. So this is mainly for the online people, right? Otherwise, it could be very cozy. But okay, we go with the routine. It's a great privilege and pleasure for me to be here in the famous THETA Rounds. I just have a quick question from the audience. How many of you has developed a model for a disease for either economic evaluation or otherwise? There are some half hands up, so I know, yeah, 1, 2, 3, 4 of you. Like that corner is like a model development corner of the, yeah, okay. So I'm happy that there are people in the room that would share some of the frustration that I have gone through developing a model for COPD. Before I start, first things first, the evaluation platform in COPD, EPIC is the name of the game. It's funded by, I don't have a laser point, right? Of course, it doesn't work on them. Unfortunately. Yeah, okay, so no worries. So EPIC was funded by a CIHR operating grant. That was the last version of operating grant before it dies and becomes project grant. And also additional funding by the Canadian Respiratory Research Network and Genome Canada. I am receiving salary support from CIHR and Michael Smith Foundation for Health Research, but none of the funding agencies had any role in the design beyond reviewing and approving the protocol. I am representing a large team of really hardworking and talented people. Some of them are in the room. Hi, Venjia. Good to see you here. It's really work of this type and scale really need a lot of good work with a lot of people. I am really representing this team. People have come and go. There is a lot of names that are not here in terms of the students and co-investigators. Each have played different parts. So the context is COPD. We have developed a reference policy model for COPD just to make sure we have a basic understanding. the exchange of oxygen and CO2 between blood and air happens in these little sacs in the lungs. They call air sacs. And in chronic obstructive pulmonary disease, either the job of the airways is to make sure the air goes and reaches the air sacs and backward. Either the terminal bronchi gets destroyed or the air sacs themselves get destroyed. That's why air kind of gets trapped in the lung and the functionality of lung is damaged. People have different flavor of COPD. Some people have this type, some bronchitis type, and some people have the emphysematous type. But nonetheless, the features of the disease are more or less the same. COPD is characterized by symptoms such as cough, shortness of breath, sputum production. The hallmark of the disease is gradual decline in lung function, which we can measure, for example, through forced expiratory volume at 1 second or FEV1 as a marker of disease activity and disease progression. The timeline of COPD is punctuated with episodes of intensified disease activity. We call them acute exacerbations or exacerbations. They are really important events. They are major source of burden. They can make patients have to be admitted to hospital. They are a major reason for mortality and so on. The main risk factors for COPD are age and smoking. There are other risk factors like environmental pollutants, work-related triggers, and even asthma is not considered a risk factor. But age and smoking are the traditional one. I think the population attributed fraction of smoking for COPD is still around 80%. And the big number is around 40% of COPD patients at any given time in our country are diagnosed. For every 2 COPD patients, 3 remain undiagnosed in the country. Again, some numbers just to talk about the overall burden, why it's an important disease to talk about. COPD exacerbations are #1 reason for Canadians being admitted to hospital, aside from childbirth and pregnancy-related issues. COPD is on transition from being the 4th cause of death to the 3rd cause of death globally and in Canada. Around 6 to 8% of Canadians have COPD at any given time, and it's what the Canadian Institute of Health Information calls an ambulatory care sensitive condition, which basically means if we do a good job providing good community care for patients, few of them will end up in hospital. So burden of COPD is to a large degree preventable. That's what makes it a relevant disease for a health economist like me, because we feel that we can do good work in reducing the burden. I take it as we all more or less know why we do develop disease models for a variety of reasons. The reason that I am most interested in, because we want to see among competing health technologies, different drugs, different screening programs, different surgical procedures, what provides value for money. We do this through cost effectiveness analysis. And the typical paradigm in a cost effectiveness analysis is that we create a so-called de novo model of patients with conditions, say Y, and then model 2 counterfactual words. In one, we provide patients with health technology X, take it as a drug, for example, and in one, we do not. And we simulate the life of these individuals so that they can collect their projected and predicted costs and health outcomes such as quality adjusted life year and calculate the incremental cost effectiveness ratio. The bottom line is we do this to find technologies that provide the highest value for money. Typically, we do this using a modeling platform called Markov models. Markov models generally work under the assumption of homogeneity of the population. The mathematics underlying the Markov model as patients are the same. If you want to introduce heterogeneity factors that might be important in cost effectiveness of your technology, you have to explicitly model them. For example, you have to model different age groups, different sexes, different disease severity levels. And as the number of these factors increases, Markov models become increasingly complex and difficult to develop and maintain. So we reviewed the COPD models in last year. Zafar, our PhD student, did. Again, as I mentioned, the paradigm is people develop one model at a time for any given health condition. Sometimes models get reused, so creating kind of a lineage. As you can see, one model has been used by 9 different people down the road, and whenever you reuse the model, you add bits and pieces to that, and models get more kind of generic and large and become multi-purpose. So it happens to other people. I am talking about my own personal story, why it happened to us that we felt that we need to develop this policy reference model. It's 2013. I am co-investigator of a large Genome Canada grant with my colleague, Dr. Seen, being the PI. And they are developing and validating biomarkers for COPD. The first objective of the grant was to develop and validate biomarkers for diagnosis of an exacerbation, so that the patient shows up in hospital, you measure something in their blood and tell them with accuracy if they have exacerbation or not. And clinicians in the room know that it can help a lot because exacerbations are very vague, can be, misdiagnosed as heart failure, as pneumonia, and so on. That will help a lot. So we are supposed to evaluate cost effectiveness of such a technology. They're also developing biomarkers for prognosis of COPD exacerbation. Basically tell people, if a COPD patient, if you are a frequent exacerbator or not. That will also help a lot in management of patients. But just think about the interaction between the two. If I develop a biomarker that can tell patients that they're going to be high exacerbators, it is going to affect the cost effectiveness of a biomarker that is downstream for diagnosis. If I am a patient that is biomarker positive as frequent exacerbators, my symptoms intensity might more easily be classified as exacerbation. And the pretest probability changes. So a biomarker for diagnosis of COPD exacerbation on top of this biomarker is going to have a very different cost effectiveness profile. So the decisions in this context are interacting with each other. That so-called de novo model development is kind of a little out of whack for this kind of questions. And some other thing to consider is biomarkers themselves are completely useless unless we bundle them with a treatment, right? You can never change patients' life with just measuring the stuff in their blood. So any decision on whether to give biomarker or not needs to be coupled with a decision what to do after somebody is biomarker positive or negative. So we are talking about multiple decisions at the same time. That's the paradigm with precision medicine when you are trying to pinpoint where the patient is in terms of the spectrum of the burden. Of course, when you develop biomarker for lung function decline, it's going to change the cost effectiveness profile of other biomarkers for diagnosis and prognosis. So it becomes an entangled set of decisions that you really cannot model just one. You cannot develop one model for each condition. As we were playing with this problem in our head, we realized that no, the typical modeling paradigm is not good enough for us. So if I want to summarize from this approach that really was imposed on me as a health economist on the grant, the lesson that I learned, first, biomarkers are hallmark of disease heterogeneity, which is really the base principle of precision medicine. You need to model heterogeneity, which Markov models don't do a good job at. First principle. The second principle, that we have multiple decisions, biomarker, no biomarker, treatment, no treatment, and we have interacting decisions. So, and Markov models are not good enough if they are developed one at a time for each decision, because they're going to fail on all these fronts. Just to add insult in injury, I was also appointed as a health economics platform leader of the Canadian Respiratory Research Network. They had their own demands, so they were coming to me with these cost effectiveness questions. And it was at that point that we decided as a team, instead of developing multiple small COPD models, let's attack this problem once and create a reference model for COPD that can potentially, theoretically, accommodate all these decisions into it and provide projection of the disease burden and cost effectiveness under these scenarios. So our solution was, the way we saw it at that time, to create one model to rule all decision analysis in COPD. It was very ambitious at that time, and we wrote a CIHR grant, we got the CIHR grant, and we really realized, oh my God, we really have to do this. A model that is going to cover the entire care pathway of COPD, from prevention strategies, from effect of potential environmental contributors to the burden of disease, all the way to the diagnosis, to management of disease, to some end stage management like readmissions after an exacerbation or end of life care. So the bottom line is it has to cover all aspects of COPD. So let's just review. The claim that we are making a reference model needs to have some mandatory features attached to that. First, we have to model disease heterogeneity in a robust manner because we are dealing with biomarker, we are dealing with precision medicine. Second, the decision node in this model should be transferable. We need to be able to evaluate the outcomes of different decisions across the entire care pathway of COPD. So the model should not be built only one decision at a time. It should be quite generic and multi-purpose. The decision should interact. Again, if you have a screening program for undiagnosed COPD, it's going to change everything downstream, because a screening program will change the burden of COPD and cost effectiveness of any COPD-related health technology. As I mentioned, the entire disease pathway should be modeled. It's called whole disease modeling in our field, and it should be open or dynamic population. So this one, the next slide is a little pedagogical. I just want to tell you what is the difference between a closed population and open population model. In a closed population model, we create two counterfactual populations, as I mentioned, at time zero, like a group of 1,000 people with treatment X, without treatment X, at a baseline year, and then follow them up over time. The way we follow a cohort of patients. Of course, some people exit from our cohort, for example, they die, but nonetheless, it's a closed cohort because nobody enters the cohort. EPIC is an open population model. Instead of modeling a closed cohort of individuals, it models the entire Canadian population from a given calendar year, say 2020 all the way to 2030. People, of course, come, they are born into this population, they immigrate to the country, and they get out of the model. So that's the difference between an open versus closed population. Why are we choosing an open population? Why do we have to do that? Because, again, consider age and smoking as a risk factor for COPD. We want to model a screening for COPD, which means that we need to model the future incidence of COPD to properly evaluate screening. And that requires somewhat considering the effect of changing risk factors. Imagine this is the average age of Canadians. We are getting older over time. So that's a risk factor for COPD. And a closed population model cannot readily incorporate that. You need an open population because we know how the age or smoking rates are affecting, changing over calendar time. Another feature of an open population model is that they accommodate some realistic aspects of technology implementation. If you have a biomarker for COPD exacerbation, it's not that tomorrow everybody in Sunnybrook Hospital is using that. There will be gradual penetration in the market, incomplete adherence over time. For example, the red lines say, oh yeah, we're going to introduce this biomarker in 2022. And we think that it will be a couple of years of improved market penetration. And after 2-3 years, we're going to have a stabilized market penetration of, say, 20%. These realistic aspects can only be modeled in an open population model because you're talking about calendar years and stuff that happens over time. So EPIC also needs to incorporate that. Complicated slide, that's basically the conceptual framework of EPIC and how it operates. I make it really simple. It's we generate random sample of Canadians, again, open population, with or without COPD, doesn't matter, 40 years old. So does patient have COPD? We decide, sorry, it's 40 years old or older. That's the population that really is at risk of COPD. So we assign some patients COPD at day one. They are coming into the cohort with COPD, say if they are older, a smoker. If they don't, we just let them stay around. There's factors such as smoking and age changes, and sometimes they die because of bacterial mortality. Otherwise, we check if they develop COPD during the course of their progression in the model. If they do, then we initiate two important aspects of COPD. It's the lung function decline and risk of exacerbation and the severity of exacerbation. Once they are here, then again loop around, they experience exacerbation, they recover from exacerbation, and again we change the risk factor. They might quit smoking, they get older, of course, and they still stay around until they die, say because of an exacerbation or because of an independent reason. Then we discard this patient, simulated patient, we move to the next patient, and we have this global clock that says starts from 2010, and we move along the global clock, simulating patient over patient over patient until we reach the end of our time horizon, say if it is 2030 for projection. So that's the engine, the conceptual framework of the EPIC model. So implementation, we were collaborating with the Statistics Canada. They have this fantastic platform called Population Health Models. It's a library of C++ codes that we got the code from them. We added COPD on top. Shazad, our brilliant postdoc, has been doing that. But in the same time, we wanted a model that we fully own and specifically that we can implement it online, provide a web app for that. So we couldn't do it with the StatCan framework. We have built a second copy as if it was not a complicated problem enough. No, we are doing two models at the same time. One is starting from scratch. Amin is our research analyst, developing it in our environment, and the other one is by Shahzad in Statistics Canada's visual studio environment. EPIC has different modules. The demographic modules take care of risk factors, sex and age and smoking status and so on. We have a module on prevalence and incidence. We have a lung function decline module, exacerbation, mortality. Payoffs are the cost and quality of life, that really the flavor of an economic model. So we are right now here, that's why these are red. We haven't implemented these, but these are our homework for future. We need healthcare encounter modules. Our simulated patients should go to simulated doctors with simulated chief complaints and go to simulated hospitals. We need to model symptoms. We need to model treatments. Something that has gone off this box is comorbidities needs to be modeled. I forgot to mention COPD is also associated with a lot of comorbid conditions that needs to be properly taken into account. Anyway, in the interest of time, I go a little faster on this, but demographic modules, again, Statistics Canada has provided us with a robust platform. If you ever want to create a reference disease model, probably you need to start from what Statistics Canada has. Projections of socio-demographic status of Canadians, province by province. Given we are working with age and smoking for this one and sex, of course, but there is income bands, there is how much tax they pay. The socioeconomic status is very robustly modeled based on Canadian Community Health Survey data that they collect every other year. So their platform is really being taken care of very rigorously. So we had no problem, for example, projecting what happens to smoking rates in Canada in the next 20 years. You didn't have to bother with that. It is already incorporated. Any question up to this point? We all good? The COPD module. So I promised to talk to you about some challenges that we had, and we can brainstorm like what goes as problems into developing a model of this type. Again, we have a prevalence population on our baseline is 2010. For example, that everybody, the entire age pyramid of the Canadians are modeled. And then we introduce what we call it incident individuals over the course of the year. We need to decide which person has COPD on day one, and what people without COPD, there must be a mechanism for them to develop COPD over time in relation to their risk factors. Problem is, prevalence of COPD can easily be measured. For example, we have this fantastic Canadian study called CANCOL, which is a population-based. They reach out to people, they measure the lung function. We know what percentage of people have COPD according to the spirometric definition and in relation to the risk factors. So with prevalence equation for COPD, we were fine. But the first challenge that we faced was with incidence of COPD, how to decide people develop COPD in the course of the model. Compare it to a disease like myocardial infarction. It's a very abrupt, catastrophic event. People come to hospital with a chest pain, and their records will be captured in data that this person has MI on this day. The definition of COPD is very vague. It's based on a threshold in your lung function. And on the day that my lung passes that threshold, it's just another day in my life. Nothing catastrophic happened. So measuring incidence of COPD is conceptually challenging. From a design perspective, is very challenging, but nonetheless, we needed equation for COPD incidence. So a little bit of a methods here. Again, prevalence equations coming from CANCOL study. We had no problem fitting a regression equation that features the logic of probability of COPD on age and sex and packages of smoking as three main risk factors. We had no way to come up with parameters for this one, which is the logarithm of the hazard, basically incidence of COPD as a function of risk factors. So how we did manage this problem? We started with a basic principle that we are assuming, given the risk factors that we are modeling, which is age, sex, and pack years, prevalence of COPD over time should be the same within a strata of these three risk factors. Assuming that we are not modeling that there is no other risk factors out there, which is what we are basically assuming in this model. these equations should be congruent in the way that if I generate future COPD patients according to this equation should still be valid, say 20 years down the road. Same relation between sex, age, and smoking and prevalence of COPD. So it turns out into an optimization problem, solving for these equations for beta primes in a way that my COPD prevalence is incident. So we solved that problem around using the so-called mathematical or stochastic calibration. Moving on, lung function module. We did not model lung function in the general population. We thought it's just too complicated for this model. We only consider lung function when people develop COPD. They have this COPD variable set to 1 in the memory of the computer. So once COPD develops, we need to initiate lung function. We had 2 sets of equations. The baseline FEV1 at the time COPD develops is coming from our national CAN-COL data, population-based sample of Canadians. Some of them have COPD, some of them don't. So if you fit a regression, you can measure FEV1 according to patients, socio-demographic status and risk factors and so on. And then FEV1 decline trajectories, we needed to estimate it from, again, another original data analysis. Yet another challenge in developing a reference model for precision medicine, probably it happens in other diseases, that evidence that is good for modeling a precision medicine ready model is simply not out there. Until a few years ago, at least, this was the way people would see COPD lung function decline. That this is your lung function at age 25 when lung is at the maximum capacity. It has an accelerated decline in COPD patients as they age. If they quit smoking, they become just, this is like normal population lung function decline. This is for COPD. If they quit smoking, then a slope becomes that of a normal population. So there's a permanent damage done, but you can prevent any more accelerated decline. And if it is too late, then quitting the smoking might not be that useful because you're already in the disability stage. And if your lung function is too low, then it can be fatal. But if you see there is nothing other than effect of age and smoking that will tell patients apart. None of those heterogeneity or patients having different lung function trajectories are considered in the body of evidence. And that was not good enough for a precision medicine ready disease model. So we had to do our homework. Zafar, our PhD student, this was core part of his PhD. He got the lung health study data. This is 11-year study. This is equivalent of the Framingham study as long as COPD is concerned. So we had access to the patient level data for this study. We ended up having to come up with this equation that really personalizes lung function decline in COPD patients. Just to talk about the methodologies in the room, it's a random intercept, random slope model of lung function decline. So FEV1 at time t has an intercept and a slope of decline and an acceleration factor, which is coefficient of time squared. And the point, the heterogeneity is modeled by these 2 parameters being actually random effects. They vary a bit from patient to patient. That is the novelty of this study compared to the previous studies, because now we have parameters that represent disease heterogeneity, what we needed for this model. Now you see this is the Fletcher-Pedo curves with a cone around them that actually is between individual variability. We know that say 65-year-old male guy, a smoker, starting at 0.2 at FEV1 2.75 at time 0. What is the trajectory of decline? The red line. This is the maximum likelihood or the expected trajectory of decline. But then we know that the person could be anywhere in this shape. It could be faster than the average. It could be slower than the average. The FEV1 might actually increase in the first year. And we knew that if the same person quits smoking, what would happen? Like the slope, as you see, gets much flatter over time. This is of course our prediction equation that we need for the model. But we also published this as just, like these are individual prediction equations for FEV1 decline. And we ended up developing a web app around it. So again, another experience developing a reference model. You have to do a lot of original data analysis, but then some of it might be rewarding. It's not just there is more than just fitting an equation for your model. You can actually publish it as, contribute to understanding of the disease you are modeling and make it available for decision making. We consider this as a decision aid at the clinical side, at the outpatient setting. You can put in patient characteristics and predict what happens to patients in terms of the FEV1 decline, in terms of the future severity of COPD, in terms of the gold grade. And when I check my academic website, a lot of people around the world are clicking on it. Some people are using it, so that hasn't been in vain. So again, our purpose was to make a reference model, but there has been some good byproducts along the way. Another important aspects of our modeling was exacerbation. Again, super important in economics of COPD and burden of COPD. And you need to model exacerbation with high level of granularity if your model is around biomarkers for exacerbation and precision medicine. This is pretty much I consider to be the state of knowledge about heterogeneity in exacerbation rate. There was a New England Journal of Medicine paper from 2010 that say, oh yeah, people are frequent exacerbators. They define it as 2 more exacerbations per year. Less than frequent exacerbators and no exacerbators. And this is from the Eclipse data, 3 years cohort study. And they say that if you are a no exacerbator in year 1, it is more likely that you remain a no exacerbator in years 2 and 3. If you are a frequent exacerbator, it is more likely that you remain a frequent exacerbator. So they basically, the message of this paper is patients are different in the number of exacerbations, and that difference seems to be a stable phenotype. If you are a frequent exacerbator, you're going to be a frequent exacerbator. Also, a recent Lancet Rest paper has challenged that, but nonetheless, it gives us the knowledge. Okay, like let's go beyond this type of work and model the actual rate of exacerbation down to the individual level instead of some arbitrary 0, 1, and more than 2. So how did we do that? Again, this is imposed on us. This is not good enough. This is good enough for understanding of COPD, but not good enough for a precision COPD model. We got access to the macro study data. Macro was a clinical trial published in New England in 2011, I guess, comparing azithromycin as preventive therapy for exacerbations and antibiotic versus placebo, and showed that if you give high exacerbators azithromycin, you can actually prevent exacerbation in these patients. You can reduce the rate by around 27%. It's a moderate reduction. But nonetheless, there was a very well-designed New England clinical trial, followed patients for more than 1,000 patients were followed for more than 1 year. So it gave us a lot of data on exacerbation, and we could fit a model that is purposefully built to inform EPIC. This model considers heterogeneity in exacerbations in 2 dimensions. First, we say people are different in the rate of exacerbation. Some people exacerbate once a year. Some people exacerbate. Some people.
With the portable X-ray tech.
Does it need an action in our room? No.
Portable X-ray tech. Please go to 10.
So some people exacerbate 5 times a year. So people are different in their tendency to exacerbate and the frequency of exacerbation. What other thing that we hypothesized at that time is that people might also be different in their tendency to experience severe exacerbation. Severe exacerbations are the ones that need to be admitted to hospital, versus the moderate and mild ones that you need to handle in outpatient settings with meds. Severe ones are the catastrophic ones. So we hypothesized that people also be clustered around severities. Like there are people that whenever they exacerbate, it's severe, versus there are people that whenever they exacerbate is more likely to be mild and moderate. So that was a hypothesis. Again, this was a Trojan horse. We needed these equations for our model. So we had this so-called accelerated failure time model of exacerbation time and a logistic regression model for exacerbation severity. And the feature of this model is this little z's here, which are again random effects. They make patients to be different from each other, either in the rate of exacerbation or in their severity of exacerbation, or both. So it's a 2-dimensional bivariate random effect analysis of exacerbation rate and severity. First of all, is there heterogeneity in exacerbation rate and severity? And the answer is yes. This is statistics called Akaike information criterion. The lower it is from a statistical model, the better fit that model provides for the data. And as you see, a model that has random effects for both rate and severity has the lowest AIC. So exacerbations are indeed heterogeneous, both in terms of the rate and in terms of severity in COPD patients. And the degree of heterogeneity is actually staggering. This is individualized, again, we are talking about precision medicine, right? This is individualized exacerbation rates estimated from our model across the sample. Though the histogram, people contribute to different bars. A chunk of people have between 0.5 and 1 exacerbation per year, but we have a good number of people that like have 3, 3.5, 4 exacerbations per year on average. So the rate of exacerbation is really variable. And I would say even more variable, this is again something new, that patients' tendency towards experiencing severe exacerbation. We had patients that only 10% of their exacerbations were severe, but we have patients that half of their exacerbations are severe. So people are, if you're really talking about precision medicine and individualized management of COPD, as long as exacerbation are concerned, we know that people are different both in terms of their rate and severity. There are other aspects of exacerbation. For example, their phenotype, they are bacterial, they might be viral. The duration of exacerbation, those are worth looking into, but like this was good enough for our model for now. So byproduct of this is that we now had a set of equations that we could model in EPIC. So any model once developed, at this stage, we had version 1 of a reference model out there, and any model needs to be validated against evidence in the literature. Does the bits and pieces of the model talk to each other in a consistent way such that the stuff that comes out of the model makes sense? So we have face validity, we had internal validity. Internal validity is like to predict some of the data that has gone into the model and to see if it can regenerate the data. This is the pattern of FEV1 decline from the model, the line, and these are the long-term study FEV1s at visit 0 to 5 and 11. So of course we use long-term study to create this equation, but when these equations is combined with other bits of the model, it survives and it gives very good prediction. This is a smoker, this is non-smokers. I had like 20 different graphs of this type, but I just cherry pick a couple for you to say, yeah, the model, this is a demographic. This is the Statistics Canada's projected age pyramid in 2035. This is 2015 from the census. So as you see, guys, by the way, our country is getting much older. Like, I think we're going to be around here, all of us. But like, you see, the entire population is being pushed toward right. And this is coming from EPIC, which very faithfully mimics not only the population size, but also the age structure of the population. So we were very happy with how age as a risk factor is being modeled. So it passes its internal validity. This is the prevalence of COPD from can cold, again, went into the model. When it comes from EPIC out, it kind of shows a granularity and a level of error that we consider to be good internal validity. More important than internal validity is external validity for a model. External validity is like to ask the model to predict something that has not been used during model evaluation, like a completely independent data set. That's your model survives the test if really it passes external validity test. And this is external validity for FEV1 decline. This is a completely independent data set called Euroscope. It was a clinical trial. They got a placebo arm, and it's only 3 years, every 6 months FEV1. And you see, this is EPIC prediction. This is observed mean FEV1. This is another cohort called PanCan. It's a Canadian cohort of COPD patients. We had only 3 time points, but still, and in smokers and non-smokers. So FEV1 module of the model makes very good external validity. It passes external validity with flying colors. This is the most rigorous external validity our model has been subject to. There are 2 clinical trials, Torch and Uplift. We never use them anywhere in the model development. And then there is this group of people, a Dutch group, that invites people who develop COPD models once a year. We hope we can be invited next year because we now have a COPD model, and does this stress testing of their models. For example, these are other COPD models out there, none of them are Canadian. Can the model predict exacerbation rates that we saw in TORCH, the red line, or uplift studies? TORCH had more sicker patients, so the exacerbation were higher. So what we did is we simulated TORCH people according to the baseline criteria. We simulated uplift patient according to baseline criteria. We ran as if you mimic a randomized clinical trial in EPIC. And we collected the outcomes, which in this case is rate of exacerbation per year. The blue bar is when you model run the uplift version of the patients. The orange one corresponds to the red line is when you run the TORCH version of the patient. So our model slightly overestimates the exacerbation rate that we see in uplift and TORCH. You can see other models, nobody does perfectly, but at least our model is more responsive, like it really models TORCH exacerbation rate to be higher than uplift, which is good news. Its relation between exacerbations and risk factors are functional in our model. I don't know if you want to declare a winner, but I don't know, maybe Wacker at the end. But nonetheless, we are doing our best as long as, but again, this is external validity. It had nothing to do with the model development. This is completely independent data. Rate of severe exacerbations, a very important part of the model. Severe exacerbations are catastrophic watershed moments that define the burden of COPD. Same group of models, same studies. Uplift, we are here, it's here, EPIC is here, TORCH is here, less than 0.2 exacerbation per year, we are here. I actually think on this one, we are the best. We are the winner compared to the other models that are out there. We have this gradient of difference in prediction power when patients are sicker. I don't see it aside from Asakai, which otherwise sucks because like it gives only half the exacerbation rate. So yeah, when Shahzad showed me this, I was in a celebratory mode, like, oh my God, this is you know the reward of all the years of work that like your model is now predicting reality, however you define it, with some degree of reliability. And of course, don't forget, uplift and TORCH are studies with finite sample size. These lines are not set in stone. They have their own confidence interval. So things are a little fudgy, but you see in the overall picture, it's quite functional. This is the mortality rate. What was observed in uplift, what is observed when we simulate uplift trial. What was observed in TORCH and what is when we simulate TORCH. We are underestimating mortality a little bit, but this was such a rare event. The confidence interval on our mortalities are huge. So we are not really that much troubled by this. EPIC, one of the main objectives was EPIC. When we got a CIHR, we put it right in the middle of the grant that we want to make it publicly available. All other models that I mentioned to you are closed in the hand of some of them are for GSK, you know, they don't even let you have access to that. But EPIC will be accessible in multiple ways. The code is available on GitHub. We're planning to create an R package for that you can download and running the model in R environment. We're going to heavily document how it works in terms of, we have a paper that we are writing, like we talk about the methodology and these validity studies that we have done. But then also there will be a technical document on how to run the model, how to play with input parameters and so on. We have a preliminary web app that you can already access. One of the earlier versions of EPIC is there. You can basically change all the parameters. These are the modules that I mentioned to you. And it throws out a lot of projections for you, not just cost and quality, on epidemiological aspects, like projection of smoking and so on. So it's really already available online, and it's a lot of work, but we are going to commit to our promise. The current status, as I mentioned to you, a bunch of the modules are complete. Some of the modules are still working. Some of the modules are not, like comorbidity is an absolute must. We haven't done that, but it will be the next version. Limitation, the EPIC model is not probabilistic. It does not consider uncertainty in evidence. It's very difficult to do that, but nonetheless, maybe in the future years, we will get enough resources to attack that problem too. When we are working with so many different parameters, correlation among parameters is an issue. Again, comorbidity module is not there. But I want to share at the end of, this is the third year of a fourth-year grant. The grant ends in, the CIHR grant ends in July, but we're definitely going to get a year of extension. But so I want to move out of the context of EPIC and just talk about, if you ever want to dare developing a reference model for a disease, like what is going to come your way, and learn from our experience. First of all, reference models that are going to be multi-purpose are very data hungry. We were lucky. UBC, my institution, is one of the biggest centers in COPD research in the world. We had access to lots of data. It's not that everybody can have access to macro clinical trial, longer study data. So we did that. I was very lucky. I didn't know at the outset that we really need to have access to so much patient level data just to generate evidence that is particularly needed for the model. We are planning to have more data in the future, so be ready to demand for data and have them available. Otherwise, some parameters of the model might not even work. It's really, sometimes the model development process become really difficult. Like we had days that from 8 a.m. to 10 p.m. I was mentally in that situation. Parts of the model do not work, your code doesn't even run, you know, you have to, I don't know, am I at a position to even advise new investigators or would-be new investigators? Maybe that's not safe to embark on this type of activity in your first 5 years of career. That's what I did. Because you want to publish, you know, you want to have like low-hanging fruit. That's top of the tree fruit. That's like, you know, that's, you need like 3-4 years just to do the groundwork to reach a stage that you can publish out of it. And don't get yourself stuck in it unless you have really done the groundwork in advance. And when it comes to model calibration, really, it becomes super crazy at times. Unlike typical, again, Markov models that you have bunch of parameters that you get from the literature, you plug it in, everything in EPIC is no calibrated. Like, to the model developers in the room, even your background mortality rates from the life tables needs to be calibrated. You cannot just put them in because you are modeling mortality explicitly for COPD exacerbation, and it messes up your background mortality table. So you need to simulate the model enough and mess around with background mortality that goes in so that what comes out of your model really corresponds to the Canadian mortality rates. And whenever there's a new study published, like Shaz or I mean, my postdocs come to me, oh, we need to implement this new parameter. This is new association between smoking and COPD from this paper, then we need to plug in. As soon as you plug in, the entire host of cards just falls apart. And you have to go back and plug in all of the, calibrate all those parameters again. So we have this routine that Amin has developed that, you know, it automatically shows you how your model is calibrated or not calibrated. And whenever we are doing this game almost every day, just how to make the model, you know, maintaining the model with the latest evidence. Be ready for that type of situation. And of course, when you put so much effort, like, you know, 3 years, 4 years of your professional life and a lot of good work by a lot of good people, you don't want to just say, oh, this is over. And that's it, CIHR, this is my final report. Statistics Canada, this is a copy of model for you. You want to be able to harness from what you have really worked so hard. And I don't know how to make this project going after CIHR funds runs over. If you guys have any COPD related question, you want to do cost effectiveness analysis, come to us, especially if you have money in your pocket. We need to, and you know, we all share the reward of having a reference model that's really, you know, is going to deliver on its promise. Well, there have been some rewards. Yes, we have been developing a model all along. We haven't published any applied evaluation based on this model that will start coming next year. But we generated new science. We got a paper in CMAJ. We got a paper in, I don't know, American Journal of Epi, in the Blue Journal, in a lot of journals during the evidence generation for this model. So that's a reward in itself. You contribute to the science. We have contributed to this Statistics Canada's framework. Our model will be no part of a Statistics Canada suite of models. They have models on cardiovascular disease, cardiovascular people are always ahead of us for some reason. They have this like 10, 15, 20 years ago. They have cancer models in it, and there will be a COPD model in a few months from now. Again, the equations that you sweat upon to develop have a standalone values. We have a clinical prediction tool for FEV1. We're going to have one for exacerbation down the road with associated web app. And believe it or not, it generates like the frustration and those whack-a-mole that you play generates quite a lot of good methodological discussion and collaboration. You know, friends become real friends during the time of trouble. That's what I have experienced developing this model. And I think I should stop here unless there are no more questions. I have some like high-level personal thoughts, but like if you guys have any questions about what we have done or overall questions, we can talk about it. Otherwise, I'm happy to share some uneducated thoughts about why we do this stuff. Any question to this point? Sure.
Actually, there is a question from Petros online, and so he asks about EPIC. Does EPIC take into consideration resource constraints, for example, limited number of hospital beds?
Very good question. No, at this stage, EPIC is a pure discrete event simulation model that works on the assumption of unlimited resources. Like you can, you know, like you can have as many hospitalization events in EPIC as the simulated patient's demand. But that's a very good point. There is certain type of modeling, mainly agent-based models, that also work on the provider, they model the provider side too. This EPIC has the capacity, the framework has the capacity, especially that POHEM, the Modgen platform for StatCan, does have that capacity built in it from a computation and a structure perspective. But no, we haven't done that. We have some, this is one on our wish list, maybe in 25 years. But nonetheless, very, very relevant question because it affects the burden of disease. I mean, we have projected like a crazy increase in COPD admissions that we know it's not to hospital, that we know it's not going to happen because simply hospital system cannot accommodate that many patients. So it's good to bring them into that equation. Andrea, you had a question too?
I was just wondering, do you really want your model to duplicate uplifted torch trials? I mean, they're very limited in the people they included, and they're controlled clinical settings. Like it seems to be that yours are probably better than theirs.
You're right. Like if you calibrate your model to the wrong target, then yeah, it's a very very painful thing that you go through all those efforts and then you're right. EPIC from the ground up is a population-based model. Clinical trials, problem with clinical trials is the heavy selection criteria and inclusion criteria that they had. So, and in specific response to your question, we tried to mimic table 1 of those studies. That's the international challenge, which is the baseline distribution of age, the sex distribution, FEV1 decline, baseline FEV1 distribution. I forget about any other thing. So we are matching on those, but I agree with you that like through patient self-selection, even within those strata, uplift and torch might not be representative of the sample of the, yeah. That's one of our defenses against why our numbers do not exactly match. We are better. We are population-based.
I think you probably are better.
Yeah. So, but on that notion, let me tell you another thing. Maybe I need your feedback and feedback of the people in the room. I had this back of my mind, something that I never disclosed to model developer team, to postdocs and analysts, as a major calibration target. Like as when everything comes close together, that this little number, that one number that I remember I was very stressed when asking Amin and Shahzad, like, what is the value of this number? And it is High reports on number of COPD admissions in Canada every year. And when everything was finished, like I asked, are you guys happy with the model? Is it well calibrated? Are you sure? Promise? And I said, yeah. And I told them, like, give me that number per year from, say, 2005 to 2015. And one of the models was crazy, was 600,000, and they realized there was a bug somewhere. These numbers is around 90,000 in Canada per year, around these years. It's rapidly increasing. but 2015, 2016, there were 90,000 COPD admissions in the country. And the model generated values around 125 or 130,000. So we are debating, is this model failing that calibration test, or maybe lots of COPD patients still go to hospital because of exacerbation, which, you know, the evidence under exacerbation comes from these prospective trials that are vigilant to capture exacerbation. But if the community is not that vigilant, then people come with COPD exacerbation to hospital, and they discharge probably as pneumonia, I don't know, or whatever else. So is it because lack of sensitivity of the ICD code in the CHI data? Is it justifiable, the discrepancy? So that's a big question in my mind. That we overestimate by around 45% the number of COPD admissions, but we believe we are the right number. Those exacerbations are real and are not captured in CHI statistics and being classified as other things. So yeah, I haven't looked at literature to look at sensitivity of ICD codes. I know, Andrea, you did some work against chart. But sensitivity might be difficult to ascertain because you need objective verification of exacerbations and then see what proportion of them. I don't know, Matthew, if you have any, like you guys do discharge patients with exacerbation, right? Do you feel that people are some that are like falling into cracks, or?
Oh yeah.
So our numbers are not that much off the chart.
No.
Yeah.
Are you using just the primary?
Yeah, CHI reports looks at primary type M diagnosis.
So maybe, you know, to relax that to look forward, you know, the other diagnosis as opposed to one most responsible there.
Okay. Yeah, because we are modeling exacerbation according to the very core, but like we are God in this model, right? We know who gets exacerbation, who doesn't. And when you do the bean counting, like I remember that day that first I was coming to my office with the number in her hand. I was like, oh my God, like, everything is going to fall apart. Like we have worked 3 years, and no, but I think that's really not an unreasonable number. I mean, if we had gone fewer than that, that would have been a bigger problem, because I assume exacerbations are, if anything, are underdiagnosed. I mean, when 60% of your population are not diagnosed to begin with, probably everything with your disease is kind of under the radar.
I think they're probably definitely underdiagnosed in people with other comorbidities,
yeah.
Like in terms of hospitalization.
So that's a defendable discrepancy.
Yeah, you said at the start, there's this clinical phenotype of the patient with increased respiratory symptoms and carries a COPD diagnosis. Some of that is an exacerbation, some of it is pneumonia, some of it is heart failure, some of it is all three, some of it is other things like PE. We're not real good at teasing all of that out clinically, especially if we're not caring to be precise about it. So it's
not like MI. I mean, yeah. and yeah, there is no troponin that you can definitely say this is angina or not.
Right.
Hopefully, unless Don gives us one, we are all waiting. So yeah, we are working with a very fluffy disease. It's very definition, like FTE1 to FVC less than 0.7. Anytime I think it might change without anything happens. Like for MI has a much more objective nature-imposed definition than like COPD, right? So yeah.
Well, also you're going to do a lot more for it, right?
Sorry?
Like you're also going to do more in hospital for it. It's probably going to generate more attention.
Yeah, that's.
And also, Mohsen, you know, not to forget that it could be as high as 20% of people with asthma also have COPD, the ACOS population. So when someone with both asthma and COPD who has an exacerbation and is in the hospital, do you call that an asthma exacerbation or COPD exacerbation? So CHI, you know, documentation may also have that kind of classification. So maybe you could also look at, you know, the ACOS population. Yeah. So come to Ontario, we could help you validate that. We have more than CHI, we have
that's very fantastic. I really like it.
And also, I have one more question. Sure. The F model, I just wonder how easy or challenging to look at other factors that may be a confounder or in fact modification to the outcome that you look at. For example, you know, the where you live and the air that you breathe, and on top of whether you're a smoker or non-smoker may actually modify your risk of having the outcomes that you're looking at. Is it easy to put that into the model?
The model can definitely accommodate it. The model, again, is built from the ground up. The fact that we chose a DES platform as opposed to a Markov model that we can throw as many risk factors as we have, as long as if we can have good data on the longitudinal trajectories of the risk factors, is association with different risk factors, and the effect of the combined new set of risk factors on the disease. And you give us the evidence from your research. I mean, we can, and again, it's an open population model. The air pollution comes per unit of time, so it helps. Yes, it is completely doable. We have provision for that. And I actually think Statistics Canada's POEM might have, I'm not sure, might have some environmental factors already built in it, that we just need to come up with a relevant risk equation. At this point, for what is really updating a series of regressions, but add one more covariate, one more coefficient, and of course, playing that crazy whack-a-mole again, calibrating everything. And once the model is there, it's, again, like I promise a yes. I don't know how much sweating is involved in achieving that.
Awesome. Yeah. Actually, a couple more questions from Petros, and then also one from James online as well. So for Petros, he's wondering, he said, perhaps maybe I missed it, but he's wondering if it's a discrete event simulation or a discrete time model.
It's a discrete event continuous time simulation, for sure. That the time is modeled continuously, yeah, in this model.
Okay, great. And also he's wondering how easy is it for EPIC to be adjusted to a different jurisdiction?
Like the other countries, because POEM is province specific. If you want to model run EPIC for Ontario versus Saskatchewan versus BC, super easy, just from global settings. For other jurisdictions, I think the parameter that needs, the module that needs to change is the demographic and risk factor module. I mean, theoretically, it's very modular. Like it's a drawer that you can remove it with a put, like say, American one. And of course, the payoff. The payoff module needs to be changing, representing cost of hospitalization in the other jurisdiction. But I assume there would be more nuances of like some of the disease specifics. Some rate of exacerbation might be different in different jurisdictions. Otherwise, again, the answer is it's doable. It needs some effort, but it's not starting from scratch. Not at all.
Mm-hmm. Great. And then from James Bowen, is the model currently not modeling the effect of treatments on the ability to avert admissions? And is the difference between the predicted and the observed admission rate the potential benefit of treatment?
Very, very, very good point. The model works with, for the torch and uplift, if you're referring to the torch and uplift trial for external validation, we focus on the placebo arm. And placebo arms are patient or maintenance therapy. We haven't modeled treatment specifically, but because all those studies that generated these parameters, nobody deprives any COPD patient from treatment. It's simply unethical. They go with the treatment, a status quo treatment. So it's implicitly modeled in the model. So see, we haven't modeled a treatment module explicitly, but our patients in EPIC are getting whatever is out there. And that is not the reason for discrepancy because we are particularly focused on the placebo arms. But nonetheless, very, very good question. Okay, I think we ran out of time. Are you guys 1 hour? Don't say it was 1.5 hour presentation. Okay, thank you very much for your attention. I really appreciate that.
Thanks everyone for coming. Thanks.
Okay. Thanks for coming.